See,
Good afternoon, everyone. Thank you,
mobile number
ISMS SICS, for giving me this
98.
opportunity. Today, I'm going to speak on mechanics of capsulorhexis.
I will send juniors.
It is a critical step in cataract
How
surgery.
much you charge? Please
So,
tell me.
optimum outcomes of a cataract surgery largely depends on the
कितना कितना
successful performance of an anterior capsulotomy.
तुमको
So,
पता नहीं
ideal capsulorhexis should be continuous, curvilinear, and correct size, circular for proper IOL centering and stabilization in the back. Continues to prevent rhexis extension, correct size for IOL centering, and to ensure anterior capsule overlapping IOL optic 360 degrees. So what is the physics behind the capsular rhexis? It is worthy to bear in mind that surgeon's hand is not the only source of extrinsic force during capsular rhexis. Another major vector of force pertains to jonular fibers applying centrifugal force, which tends to divert the tear direction towards the periphery. So capsular axis requires a perfect balance between these two forces. As we know, lens diameter is around 9 mm, so jonular insertions on the anterior surface spans around 2 mm, so available surface on the anterior surface around 6.5 to 7 mm. So when a capsular tear encounters a jonular fiber, the resulting jonular forces direct the tears towards the equator. And this force, out of vector force, further increases if the lens moves anteriorly as a result of increased vitreal upthrust or decreased anterior pressure by the leakage of OVD from the anterior chamber. So now the concept of shearing and tearing. Shearing occurs with the flap folded. As we see from this diagram, if the paper is folded and it is the tear point is traveling in the same direction as the applied force, and here one fiber is broken at a time, so it requires the least force to advance the tear point and it's a more controlled technique. Whereas in ripping, we see if the torn paper is in the same plane as the rest of the paper, like if rest of the paper, so many fibers are pulled, all at different angles and with different force. Breakpoint will not be continuous, so therefore uncontrolled. So performing the capsulorhexis when the instrument is close to the tear point, this is the condition for shear. When the instrument is at greater distance from the tear point, this is the condition for rip. It is a good idea to stain the capsule. For the beginners, it reduces the elasticity and increased stiffness of the capsule. It can be done with the cystitome or forceps or combination of two. It is like needle should be bent at around 45 degrees. It ensures good visualization of the tip and better control of the flap in the subincisional area. And for the forceps, it can be done with the Utrata forceps, McPherson forceps, or microcapsulorhexis forceps. The mechanical difference between the needle cystitome and forceps is that, like, needle cystitome works in X and Y axis, whereas forceps works in Z axis as well. So whenever there are conditions like jonular forces are, we have to counter the jonular forces like intumescent cataracts, pediatric cataracts. It is a good idea to do with the forceps. So for the continuous curvilinear capsulorhexis, for the good centration of the capsulorhexis, always pierce into the anterior capsule near the center of the cornea, taking Purkinje images, because it is a marker for the visual axis, and make the tear till 1/3 distance between the center and the limbus, then fold the flap, and the flap should always be flat on the anterior surface. Then, now where to hold the flap? For example, for this, like from the pivot to the lever arm, it should be at the 1/3, 2/3, and 1/3 junction of lever arm to get optimum control on the torque moment. This can be explained by the rule of triangle. Like this concept is given by Dr. Saurabh Patwardhan. Like you can imagine a triangle of 1 to 1.5 centimeter. Apex of this lies on the advancing tear, one side along the flap fold and one side along the flap margin. When the cystitome needle holds the capsular flap on the center of the triangle, we get maximum control on the further movement of the flap. For the continuation, it should be rotated at least for each 45 to 50 degree of anterior capsule tearing to accomplish a well-shaped capsulotomy. For the completion of the rhexis, notch should always be pointing to the center, because if the notch is pointing outwards, it can lead to anterior capsular tear, which could extend into the posterior capsule. So the forceps capsule rhexis, it is possible to complete more clocards of CCC at a go than with the cystitome. It can be useful in fibrotic atrophic elastic capsules, Morgagnian intumescent, posterior CCC, pediatric cataracts, and where we are not able to counter the jonular attachments. So before leaving the flap, it is necessary to reposition the flap. For the cross-incisional area, it should be vertical and standing. For the sub-incisional area, the periphery of the tone should be flat and parallel to the pupillary border. These are the, you can understand this like danger zones. Like these are the two red zones where the elasticity is like more. So we have to be careful in these zones. Don't try to re-grasp the capsule again and again these zones. You can use Rexus markers for the better centration of the Rexus for the utilization of the advanced optics of today's premium IOLs. Now, applying these principles, we want to find why our CCC extends. So, application of the wrong forces, cutting or ripping, or the right force in a wrong manner are the major causes of extension of CCC. So, we should find out if the AC is shallow, we will fill with OVD, increase intralenticular pressure. If your size is going beyond 6-7 mm, vitreous upthrust, superior rectus muscle suture, if there's a tight speculum. So, take home message is like AC should be well filled to maintain shape. Use high magnification during the operation. Look for the red reflex. Use high molecular weight OVDs. Operate slowly and carefully. Start at the middle with the formation of the flap and continue under the tunnel, then on the remaining 360 degrees. Keep Rexus always flat on the lens surface. Repeat capsular grasping several times, which means opening by sectors. Complete Rexus from outside in rather than inside. Keep the opening within the limits of zonular fibers. A small Rexus is easier to perform than a large one. It can be widened at the end of the implantation, where the large one will tend to escape. Irregular Rexus is better than with tendency to escape. Should the smallest sign of escape appear,
Please
use
conclude.
OVD of high molecular weight. Thank you.
Thank you, Dr.